Assalamualaikum, good morning. Thank you, Prof. Imran, for that very kind introduction. I'll just try to share my screen first. Okay, so today I'll present focusing on the role of cardiac MR in the management of ischemic heart disease. So I want to start first with a brief introduction on cardiac MR. So CMR is an imaging modality that able to comprehensively assess cardiac anatomy, function, perfusion, and tissue characteristic in a highly reproducible manner. Due to its many advantages, MR continues to undergo large expansion of its role, both in clinical practice and also research. So what are these advantages that we talk about? So cardiac MR has no application of ionizing radiation or administration of radioactive isotope. So this is preferred when we expect, especially in young patients, and also when we expect to do repeated examination. It also has high spatial and temporal resolution when compared to other cardiac imaging modality. So number 3, the image can be acquired throughout the body in any tomographic plane. So it allows interrogation of specific structure in question. Echocardiogram remains an indispensable cardiac imaging to us due to its lower cost and portability. But in some patients, the echo-acoustic window just poor, so cardiac MR would be good to solve problems in these scenarios. It has bigger field of view, and it is a multi-parametric examination, so it allows complete comprehensive assessment for anatomy, function, tissue characterization, perfusion, and also valve anatomy and flow. In some conditions, CMR can offer one-stop imaging evaluation. So it also have high reproducibility and low intra and inter-observer variability, and it can assess for volumes without any geometric assumption. Okay, so in relation to ischemic heart disease, there are 2 main CMR protocol that we normally use, which is CMR perfusion and CMR probability respectively. So in this presentation, I'm going to talk mainly on this protocol. And this protocol help us in answering many, or at least the very common and important clinical questions in cardiology practice, which is, what is the cause of a patient chest pain? In fact, this is exactly the common indication and the common question in our cardiac MR request. Is a patient having chest pain? Is it significant CAD? If it is coronary artery disease, how significant it is? How much ischemia or how much ischemia burden does it have? And also, what is the best management strategy? So the cardiac MR can help us answer all these questions. So we start by the first protocol, which is the MR perfusion. Most of the recommendation, the illustration tables that I use in this presentation comes from these 2 guidelines by EAC, recent guidelines by EAC on the chronic coronary syndrome, as well as on myocardial revascularization. Right, one of the major recommendation change or major upgrade for the non-invasive functional testing is that they have been upgraded as a class 1 initial test to diagnose coronary artery disease in symptomatic patients when obstructive coronary artery disease cannot be excluded. Another one of the widely used tests that people normally deploy to investigate chest pain is the coronary CT, but it is worth noting that in many cases that the CT, when they interrogated the stenosis, but it cannot ascertain the functional significance of the stenosis. So in such situation, the functional imaging is recommended to add further information. This is something similar, but this one is from the myocardial revascularization. So we can see that all these functional tests, including MR, stress echo, nucleus PAC, and the PAC perfusion, all are given class 1 indication in the patient with intermediate pretest probability. So we know that there are few tests available in this investigation modality. So how can we tell, or are there good reasons to choose cardiac MR over the other investigation? Firstly, so we should remember that the PET, CT, and SPEC would involve ionizing radiation and the radioactive isotope. And secondly, there are many studies and there is large of evidence that shows how the clinical accuracy of cardiac MR is better when compared to CT and SPEC. In this particular study, they use invasive FFR, which is we know is the diagnostic reference standard or the standard of care when we want to diagnose a coronary stenosis of the hemodynamically relevant coronary stenosis. So in this study, we learned that MR have as good as diagnostic accuracy to PET and superior when compared to CT and SPEC. So CMARC trial is one of the early landmark trial that showed how perfusion MR has better sensitivity and better positive predictive value when compared to SPEC. This is just the illustrations of the result from the CMARC trial, where they used different cutoff points to determine the diagnosis of significant coronary artery disease. So this is a meta-analysis by JASMA. I think this is a study that they pulled probably more than 37 independent or small studies or multi-center studies. And in this meta-analysis, it shows that MR, again, have better similar sensitivity and specificity when compared to PET and superior when compared to SPEC. This is one of the newer meta-analysis. And again, we know how FFR is the standard of care when diagnosing significant coronary artery disease or hemodynamically relevant coronary stenosis. So in this study, I think they pull about 3,000 patients, and from the results, it shows that MR had the highest performance to diagnose ischemia-causing coronary artery disease, with low performance when compared to SPEC, stress echo, CT, as well as invasive coronary angiogram. So this is just a table to show the sensitivity, specificity of all this investigation. So what about its prognosis value? So we have, again, many studies that shows how perfusion MR able to discriminate patient with low risk and patient with high risk better than other modality. This is again another meta-analysis by Handel, and from this analysis, he showed how that patients with normal perfusion CMR has a very, very low risk of major adverse cardiac events. And conversely, when the cardiac MR perfusion results or findings is abnormal, patients will have higher risk of cardiac mortality, whether or not a patient is known to have ischemic heart disease or not known to have coronary artery disease. Right, so we move on to the second protocol, which is the viability. In the signature sequence in the viability protocol, which is this viability protocol actually form part of the perfusion, CMR perfusion protocol as well. So the signature sequence is called the lead gate enhancement. In this sequence, the gadolinium, which is the contrast used, would be retained in the extracellular cell when there is myocardial disease such as infarct, fibrosis, or edema. And those areas will look bright and enhanced on the images. So the distribution, so this lead gate enhancement gives us a lot of clinical input. Firstly, its distribution or its pattern of distribution will tell us the underlying etiology. For example, like shown on the image there, if the enhancement is subendocardial in nature, it means the underlying cause of it is a myocardial infarct. Secondly, so besides the pattern of distribution, when a scar is due to an infarct, the scar thickness, or we also call the transmurality, will tell us whether the myocardial segment is viable or not. And the information of its viability normally can help to guide the management strategy. And also, the presence and the extent of the ischemia or the scar burden invariably will tell us about the patient prognosis. So this image panel simply just to show how the lead gate distribution can help us to identify or to diagnose the underlying cause of a myocardial disease. For example, A is a normal myocardium because we cannot see any myocardial, any enhancement there. B, we can see that there is a brightness of subendocardial pattern. So the underlying cause is very likely to be myocardial infarct. And C, there's a diffuse and patchy enhancement at the hypertrophic myocardial wall, which is found in hypertrophic cardiomyopathy. So this is to show how when an infarct, subendocardial scar due to infarct is present, how its thickness can tell us of the viability of the myocardial segment. So if the infarct thickness is more than 50%, the myocardial segment is considered to be non-viable or absent viability. If the scar thickness is less than 50% or there's no enhancement, the particular myocardial segment is considered to be viable. This is from the very first landmark paper on the myocardial viability by cardiac MR. So this is, in this study, it has shown how this viability suggests the likelihood of functional recovery of the myocardial segment. So it shows here how once a myocardial is not viable, which is when they have more than 50% scar or infarct thickness, that the the likelihood of functional recovery is about 10% or less. And obviously, if the scar thickness is less than 50%, the myocardium is viable, the chance of functional recovery is so much better. Okay, so this is one of a newer work by Peck et al. So in this study, they have asked a specific question, which is what is the number of myocardial segment that can predict global functional recovery after patients undergoing coronary bypass? So if a patient for those who are not familiar with this, in practice, we divide the LV ventricle into 17 segments, and we consistently use this in all our cardiac imaging reporting. Okay, their result shows that based on a 50% transmural cutoff, patients with more than 10 viable segments would improve their global LV function post-bypass, while patients with fewer such segments would not. And this is from the recent guidelines on myocardial revascularization. They recommend that the non-invasive stress imaging, which including cardiac MR, may be considered for the assessment of myocardial ischemia and viability in patients with heart failure and coronary artery disease before the decision on revascularization. So in summary, in patients with chest pain, cardiac MR able to diagnose significant coronary artery disease due to its multiparametric capability. They would detect this by diagnosing regional wall motion abnormality, detect the presence of scar or infarct, and also to detect perfusion defect. If the perfusion defect shows large ischemia, it should benefit from revascularization. If a patient CMR perfusion study is normal, invariably they have very low annual risk for major adverse cardiac event. Sometimes it's also allow evaluation for non-coronary cardiac chest pain, such as microvascular disease, pericarditis, hypertrophic cardiomyopathy, and also aortic stenosis. Secondly, in patients with heart failure and coronary artery disease, MR able to determine its viability and guide management strategy. Okay, so we should go and see some cases. So the first one, Mr. SMS, he presented in a private hospital with chest pain. The angio showed triple vessel disease. He's planned for PCI to proximal LAD, but patient was not cared for another intervention. He came to our hospital to seek for second opinion, and the referring physician decided, the cardiologist decided, that we should look for evidence of ischemia. So this is the cine images of the patient. So if you look at this particular movie, we can tell that probably the contractility mildly impaired, and probably the LV look a little bit or mildly dilated. Otherwise, I don't think there's any gross abnormality from these images. This is the long axis two-chamber view. Again, not much there. This is the money shot practically. So this is the late gate enhancement. On this image, we can see how there's presence of almost transmural, near transmural enhancement in the lateral wall. This is probably due to his history of previous MI. And on the two-chamber views, which covers the anterior and the inferior wall, we could not appreciate any enhancement. So he probably have an infarct involving the left circumflex artery before. So this is the images from his perfusion study. So we cannot make these moving images. We cannot make this into a movie. However, so this is his perfusion study, and we can see there's a perfusion defect present at the anterior wall, as well as and some defect present at the septal wall as well, that extend from the mid LV, and this is the images from the apical segment. We can still see those defects involving the apical anterior and apical septal, which all should suggest LED disease. So following this MR examination, patient had agreed for intervention, and he had underwent PCI to LED successfully. So second one, Mr. NR, he already had previous PCI. His EF is low, 24%. This is again a common indication or request for cardiac MR probability, which is to assess probability prior to coronary bypass. So the finding, again, the EF is low. He's got multiple subendocardial infarct in multiple segments, which in keeping with triple vessel disease. However, only one non-viable segment, which suggests that all the infarct present has less than 50% transmurality. Let's look at the images. This CME is not moving, but this is from the SSFP sequence. Normally we use this to assess overall contractility to measure the volumes, but this sequence will not allow us to characterize the tissue or detect any disease in the myocardium. This is again the signature sequence of late gate enhancement, not the best examination, but we can see there's a bit of enhancement that involve the septal wall and basically which present at the apical segment, but we can agree that the enhancement or the scar thickness is less than 50%. This is a long axis chamber, the long axis two-chamber view. And again, we can see that the enhancement is of subendocardial pattern, which suggests in an infarct, and the scar thickness is less than 50% and is present at anterior wall, which is related to the LED. This is a short axis view. Normally, the short axis view are better for diagnostic purposes when compared to the long axis view. So this is at the basal of the LV. We can see the presence of less than 50% scar at the inferior wall, and again, scar at the anterior wall and at the apex at the anterior wall. So I would agree that he's got multiple segments of scar, but all of them less than 50%. So essentially, he has only one non-viable segment. Bypass was done, and his post-bypass LVEF has improved to 32%. So the third one, I've got just another two more cases. We should be finishing soon. The third one, Mr. RB, another case triple vessel disease with EF of 36%. So CMR request for viability, KIB for bypass surgery. Similarly, this case also viable, mostly viable myocardium. Again, he has only non-viable segment in one segment. So not moving. So we can see that his myocardium, no enhancement at the basal, at the mid, and only at the apical wall. Probably quite thick scar at the apical segment. So we agree there that he's only have one non-viable segment. Bypass was done, and there's a lot of improvement in his LVF to 51% post-surgery. And this is my last case. This patient, Mr. A, have got recent MI. He's planned for bypass. Again, noted low LVF. And he's finding apparently he's got viable LED, which is important for surgeons, but mostly non-viable RCE or the RCE and the left circumflex segments. And he's got total non-viable segments of 12. And so because of this, he considered not suitable for bypass, and the cardiologist decided to do a selective PCI to his LAD instead. So this is the cine images. So it doesn't really play. So we can't really see his contractility. I'm sorry about that. And this is the lead gate enhancement at the two-chamber views, which shows us how that he has quite a bit of scar at the anterior wall as well as at the inferior wall, and near transmural scar at the lateral wall as well. So if we go, this is the basal segment at the mid segment, so near transmural scar at all the lateral wall and the inferior wall. So those are the circ and RCE territory respectively. So this is from his corneal angiography, his RCE, so we can see how extensive disease that he has, leading to small caliber RCE. This is the image from the LED. Those are the lesions that considered significant by the interventional cardiologist, and he decided to put a stent at his proximal LED. Okay, that is my last slide. Obviously, thank you very much.
Excellent talk, Ashikin. Thank you very much for the overview of cardiac MR in managing patients with ischemic heart disease. We have 3 questions for you. Okay. The first question is: can cardiac MRI use to monitor ischemic heart disease post stenting or CABG? What is the effectiveness compared to angiogram? Meaning to say that, what do you do in a patient who had an angiogram or angioplasty or a bypass, whether we should follow them up with MRI to see for their progress? What do you think?
So the question doesn't appear on my chat, yeah, Prof. It's only to you, right? Okay, okay. But I wasn't following. Prof, what was it again? So you wanted to know?
The question was whether or not we can use MRI to monitor a patient that has done stenting or bypass.
Perfect.
So can we use that to objectively say that, oh, you're doing okay, or oh, you're getting blockage again?
Yes, yes. So the key word is to repeat. Yeah. So one of the advantage of MR that in the absence of radiation applied, so they become its strength that when you expect repeated examinations, and also we do know that when compared to other modality, that its assessment of volumes and function is the gold standard practically. So it's a perfect modality if you aim to evaluate your patients, whether they have, if they have improved or otherwise following an intervention.
You realize you're opening the Pandora's box by saying that, because then you all this. So you must tell us then what is practical, because I'll be sending you every year. I'll be sending an MRI, cardiac MRI to you.
Yes.
Right? So what would be the best thing? What would be the best patient that we will send for MRI?
What would be the best patient to send? I think if we, normally in practice, the limiting factor would be the cost. And also, obviously, in this talk, I did not mention its limitation and contraindication, which is, besides the cost, is also long scanning time. So the waiting time for the list can be quite lengthy as well. But otherwise, if they aim to get information, is a very good test to to request. Yeah, but if we take into consideration of the cost and the long waiting time, and some patient might not able to tolerate cardiac MR very well, because we still use what we say quite old protocol, which patients need to do a lot of breath holding. So patient can be fatigued in the middle of examination. So in short, I do think that at this, most of patients that we ask for MR when we have a need to answer one specific question. We have not yet practiced doing MR to evaluate patient progress. This is what I noticed in our practice.
Okay then, let's proceed to the second question. Which of the two is better, angiogram study or MRI in studying perfusion issue prior to revascularization? So let me correct that question a little bit. Which is better, FFR in an angiogram study or MRI to study
Oh, the
perfusion?
you must know this, Prof. So the invasive FFR is what considered reference standards, which means all these trial, when they want to see the efficacy in diagnosing hemodynamically relevant coronary stenosis, they need to use the invasive FFR as a reference standard. And in many of these trials, their outcome endpoint would be to show that it's non-inferior to FFR, invasive FFR. So, but the way to see it is that when we know from all this study that we have done, I did not put it in my presentation today, but one of the latest big trials that we think is important in practice, which is called the FOM, just published in NEJM last year. So what they do is to strategize patient using cardiac MR perfusion from very beginning, compared to the strategy using invasive FFR. So in this patient, they found out that the strategy using cardiac MR perfusion have got not inferior outcome when compared to patient with the invasive FFR as the management strategy. So we can't say it's a superior, but in selective patient, the CMR perfusion strategy would be just as good, especially when patient have intermediate pretest probability, and also when patient not keen to go to invasive intervention straight away.
Great. So we can say it's not inferior. Okay. So nowadays, since we have a lot of our colleagues getting older, they'll come to see me and say, "Oh, I'm worried whether I've got coronary artery disease. My family has one. I would like to screen for my heart." That's a typical test, kan? So the guideline says that we can choose non-invasive methods, right? CT coronary angiogram, or even MRI. So in your opinion, if you put aside waiting time and the cost, what would be the best non-invasive modality to screen for coronary artery disease in patients with risk factors?
Right, this is excellent question, Prof. And I wouldn't say it's really my opinion, but it's quite clearly stated in the guidelines. Yeah, so if I refer to the category of patients that you mentioned, it sounds to me they are at least intermediate. Yeah, because they are older and have got a few comorbidities, for example. So the best assessment for them. So we do know now that exercise stress test, not only many patients not able to do it well, but it also has been downgraded to only class 2B for assessment of possible CAD. So that's make it not the preferred test anymore. So among the functional tests, the other widely used one would be the CT. But in intermediate patients, especially the older one, there's a good chance that some plaque disease might be detected. But in the absence of information from the functional test, CT were not able to decide whether those blood diseases are significant or not. So that gives us only the functional tests as the better options. So among the functional tests, so from the presentation I've got, I tried to show how MR has a superior diagnostic accuracy when compared to SPEC, when compared to stress echo. It's probably similar capability to PET, but PET, we know it emits the radioactive isotope. Again, make it not so attractive options.
So having to say that, it is better for me to order cardiac MR for this group of patients then, instead of CT.
Yes, indeed. Very true. Yes.
The Pandora's box, you will probably get patients from me.
All right. We have no problem with that. I'm more than happy.
Okay, so we have passed 9 o'clock, and
Uh-huh.
everybody has get to go to work, especially me. I'm still at home. So I would like to thank both speakers today. Excellent talk, both of you, Dr. Prof. Loh and Dr. Noor Ashikin, and for the review on the surviving cancer and also cardiac MR. Please join us again next session for more information, which I'm not sure when is the next session, but I would say today was very fruitful. I've learned a lot, even in the field of cardiac MR, and where I thought I knew a lot, but definitely Ashikin has opened more new information for me. And to Professor Loh, again here, I admire your passion in this rarely visited area of rehab medicine. But again here, that's the objective of this Faculty of Medicine breakfast session, is to see new new aspects of medicine that not just enclosed in just cardiology for me. Now I've opened my eyes into rehab medicine. So that's all. Thank you very much to all the participants and your questions.
Thank you so much, Prof.
All right, so I shall leave you everyone now. Assalamualaikum warahmatullahi wabarakatuh.